This is Adrenia Tolliver. I'm the Public Health Preparedness Training Coordinator here at BDH, and I will be facilitating tonight's Polycom titled Behind the Scenes of an Epi Outbreak, Ebola. This is a MRC volunteer training, so we want to welcome everyone who's on the line. Again, make sure that you register in train with 1061398 as the course ID. And make sure, MRC coordinators, that you send me the sign-in sheets for those who are in attendance tonight, and I will verify them in train for you. You can scan it, fax it, take a picture on your phone, send it to me any way you can to make it easy, and everyone will get verified in train. Also, we will have the PowerPoint deck will be available to you. I will be emailing that out to all of those who register in train as well. A couple of housekeeping notes. Please put your mics on mute unless you are speaking. Our speakers will take all questions at the end of the presentation, so we'll let you know when that is. And we will actually have a little bit of a break in between our speakers, about a 5-minute break or so to give you time to stretch your legs. Again, make sure you register. And MRC coordinators, make sure that you send me your sign-in sheets. Or you can just email me the names. That will work too, of those who are attending tonight. So let's go ahead and do a few introductions of our speakers. We have with us Jyoti Gupta. She is a monitoring program supervisor at Virginia Department of Health, Division of Surveillance and Investigation. Her current role involves statewide coordination of efforts in outbreak investigation and data management, as well as administrative supervision of DSI monitoring team at the central office in VDH. Prior to her current role, she served as a program evaluator, providing evaluation and sustainability support to several federal funded programs in Virginia, and also served as a board member in a nonprofit organization. She has a graduate degree in public health. She has also worked as a research associate at Indiana University and has designed, implemented, and analyzed research projects with a recent publication in a peer-reviewed journal. In her spare time, she engages in creative art, ethnic cooking, and spending time with her family and friends. And this is Jyoti. We also have with us Mary Beth White Comstock. She is an infection prevention epidemiology consultant for the Virginia Department of Health in the Office of Epidemiology and the Centers for Disease Control and Prevention. She is also a clinical assistant professor in the School of Nursing at the University of Virginia. She received her bachelor's and master's degree in nursing from the University of Virginia, and holds a Doctor of Nursing practice with a concentration in public health leadership. She has extensive experience in developing and implementing infection prevention initiatives in all types of healthcare settings and on both state and federal public health levels. She has been involved in leading state and national Ebola preparedness activities and leads the Ebola hospital assessment efforts in Virginia. And in Arlington, we have Denise Sockwell. She is an epidemiologist with the Virginia Department of Health and Division of Surveillance and Investigation as well, working with the Northern Virginia region. In her 15 years with the department, she has specialized in communicable disease control, outbreak investigation, epidemiology, response planning, and disease surveillance. Previously, Ms. Sockwell worked with CDC and in the local health departments in North Carolina and Tennessee. Ms. Sockwell has presented at numerous state and national conferences on the topic in epidemiology and public health. She received her Master of Science in Public Health from the University of North Carolina at Chapel Hill. And our last presenter, who is also in Arlington, is Dorothy Biernerser. Hope I said that right, Dorothy. Sorry. She is a RN. It's been an RN since 2006 and has worked full-time for a while before going back to non-nursing employment. She has kept her license up to date, such as in ACLS and PALS. She has been a MRC volunteer since 2009. She currently works as a volunteer in Fairfax. And she graduated in CERT in class 97 in May of 2015. So these are our presenters for this evening, rather. And so we want to go ahead and get started.
Hi, my name is Jyoti, and I'm going to talk about the 2014 Ebola outbreak and Virginia's response. In this presentation, we're going to summarize, first of all, the mode of transmission, what the Ebola virus disease is, what the clinical manifestations are, and explain how this Ebola virus disease became an international epidemic. Describe the impact of Ebola in Virginia and what are the lessons learned for future outbreak investigations. Describe Virginia's response in general, give an in-depth insight into the Ebola disease surveillance and investigations, and then highlight the Medical Reserve Corps' role in Virginia's response to the Ebola and future disease outbreaks. So Ebola virus disease is a viral hemorrhagic fever. And it was first discovered in 1976 in Zaire, which is now the Congo Republic, near Ebola River, and that's how it gets its name, Ebola virus disease. And it can be very severe, characterized by hemorrhage, as the name suggests, and often fatal. Disease affecting both humans and non-human primates like chimpanzees, monkeys, gorillas. The Ebola virus, there are 5 subspecies of this virus. And the 4 subspecies cause disease in humans. In the 2014 Ebola epidemic, it was the Zaire Ebola virus which was identified. And you can see over here there's an electron micrograph of the Ebola Zaire virus. So the Ebola virus disease is transmitted first from the bite of an infected animal, a fruit bat. And once this animal bites the human or a non-human primate, from then on, this virus can be transmitted from person to person through either direct contact with infected bodily fluids, including blood, or even through exposure to contaminated objects, which are contaminated with infected body fluids. This disease can be transmitted especially when the person is symptomatic, and the highest risk of transmission is during the later stages of illness, when the person can have hemorrhage and other symptoms. So the clinical manifestations include fever, headache, myalgias, weakness, fatigue, back pain, and the predominant symptoms are GI, that is nausea, vomiting, diarrhea, abdominal cramps, and there can be, in severe cases, unexplained bleeding, bruising, rashes. In the disease, the epidemic started in West Africa, and the fatality rate over there was found to be 50 to 90%. The time from the exposure to the Ebola virus to when the symptoms actually develop, that is the incubation period, ranges from 2 to 21 days. In general, there is no treatment, no antiviral treatment for this Ebola virus disease, and the treatment is largely supportive through rest, IV fluids, through fever and pain-reducing medications. Vaccine trials have been in place throughout the outbreak, and there has been a lot of success in that, but once the outbreak came to an end, we couldn't really assess the efficacy of the vaccine, but there's still a lot of data on the safety and immunogenicity available for future purposes. So this slide tells us about the timeline of the major Ebola events happening all over the world. The first person who fell ill and unfortunately passed away was in Guinea, and that was an 18-month-old child who was playing in his backyard and got a bite from an infected bat, his household members got affected, and thereafter the disease spread to other people in Guinea, and then with the porous borders, the disease further spread to Sierra Leone, and then gradually, with a lot of traveler movement, the disease spread to Nigeria, Liberia. In Nigeria, there were total 20 cases, and the disease was under control. But the three main countries in West Africa that were affected with Ebola were Guinea, Sierra Leone, and Liberia. And by the time it was August 2014, the World Health Organization declared this to be a public health emergency of international concern. By then, there were more than 1,000 cases and deaths, and September onwards, the vaccine trials began. Meanwhile, there was a lot of international aid coming to those countries with an aim to control the outbreak. The person-to-person transmission was also observed, and that went across West Africa to Europe and US. And in October 2014, healthcare workers in US were also diagnosed with Ebola virus disease. Finally, as with every outbreak, there is a peak, and then there is, the outbreak starts trending down. Even though the outbreak started trending down starting May, June of 2015, it took many months before we actually came to 0 cases. So initially it was Liberia that was declared Ebola-free, followed by Sierra Leone that was declared Ebola-free in November, and then in Guinea was declared Ebola-free as the last country to be declared Ebola-free in December 2015, and that's when the Ebola came to an end. Meanwhile, there were a lot of events happening in the US too. The major events happening in terms of the healthcare workers being affected. So in total, there were 4 healthcare workers between August and October of 2015 who were diagnosed with Ebola virus disease. And as they were diagnosed, there was a lot of contact tracing happening as well. In October 2014, also travelers who were coming from West Africa into US through the 5 US airports started getting screened for Ebola virus exposure, and their information was divvied out to state health departments, and then states were required to actively monitor travelers coming from West Africa. October 2014 was also the time when Virginia established the Ebola Unified Command, and that was really, really crucial to have a very organized statewide coordination of efforts of preparedness and response. States started monitoring travelers, and in December 2014, also CDC and ASPR issued hospital guidance about the tiered approach, which is really important to set a stone for a strategic assessment and care available for patients who have Ebola or for travelers who are suspected to have Ebola. And with time, the monitoring started coming to an end. Liberian travelers were no longer required to be monitored from June onwards, and then eventually November and December of 2015 marked the end of monitoring for Sierra Leone and Guinea travelers. In this slide, we can clearly see the peak and the trending down of the confirmed Ebola cases worldwide, and this graph is taken from CDC all the way from March 2014 to December 2015, which is the timeline for this graph. And we can see the blue in this graph refers to the confirmed cases in Liberia, and the teal color for confirmed cases in Guinea, and the gray color for confirmed cases in Sierra Leone. And we can see that in early 2015 and late 2014 where we had the maximum confirmed Ebola cases, and then it took many months ever since, all the way to the end of 2015, to really reach to 0 cases. Per WHO reports, there have been 28,637 cases, including more than 11,000 deaths. The last 3 cases were found in Liberia in November of 2015, and Guinea was the last country to be declared Ebola-free. So a lot of efforts were happening throughout the world and throughout the US and in Virginia for preparedness and response, for control of the Ebola outbreak. The best defense is a good offense, and a lot of resources were invested, a lot of time, money was invested to prevent transmission in the US and to support the ongoing outbreak control efforts in West Africa. The US government took this outbreak very seriously, and definitely beyond an issue of national security and as an opportunity to demonstrate leadership. The US policies were established to educate people, to inform them more about what the Ebola virus disease is and how its transmission can be prevented. There was enhanced screening at the airport of travelers coming from Ebola-affected countries to see whether they have had Ebola virus exposure, and then their information would be sent out to the states, and the states would engage in actively monitoring those travelers to make sure that they're able to identify symptoms, if any, on time, and symptomatic persons could be offered prompt isolation and care to prevent the epidemic from happening in the US. So apart from raising awareness, generating a lot of training materials and media releases, and coordinating a lot of efforts across agencies, across different personnel, also lab testing capabilities were expanded. We had more than 50 labs all across the US in 44 states who had the capability to do Ebola testing. A lot of efforts were in identifying hospitals and hospital systems beforehand to make sure that there were designated places for Ebola assessment and for Ebola treatment if required, and to make sure that there's protection offered for healthcare workers. So the Virginia's response for preparedness and response was extensive and intensive, and one of the key things for Virginia's response was the extensive coordination with the partners. And these partners were across multiple agencies, whether local health departments, whether public and private hospitals, whether state and local law enforcement agencies, and the Virginia Department of Emergency Management, the emergency medical services were also involved for appropriate patient transportation, and then even coordination with the laboratory facilities to make sure that there is laboratory testing and the resources were available, including resources for shipping specimens, for transportation of samples, and also coordination with hospital preparedness and hospital systems for preparedness and assessments, and also a lot of coordination involved in risk communication. So one of the key things in Virginia preparedness was establishment of the Ebola Unified Command, and this was established in October 2014, right when the travelers started getting funneled at the airports and screened at the airports for active monitoring. And this Ebola Unified Command was really key to giving an organized structure to the statewide coordination of preparedness and response efforts. These are some of the objectives over here, which I just mentioned, that objectives to coordinate interagency and interjurisdictional actions, but there are many other, for example, medical waste management, or even for behavioral health, and many others. So this is a snapshot of the Virginia Ebola Unified Command, and you can see right from the top, we start with the governor's cabinet and going on to our top management, our state health commissioner and deputy commissioner, and then how it trickles down to the law enforcement, the those involved in the planning, operations, finance, logistics, people who are working with the EPI response, and the public health branch. We have our hospital readiness teams and other specialty teams, and a lot of people involved in regional coordination. So this is really, really important. So in Virginia Preparedness and Response, we developed guidance and procedures which were in place for isolation and quarantine orders if they needed to be issued, for active monitoring of travelers who came to Virginia, even for case contact management, for management of PUIs, that is persons under investigations who were suspected to have Ebola or symptoms that resembled Ebola, and healthcare workers in Virginia caring for patients. The good news is we never had an Ebola case in Virginia, so that's the good news. But there was extensive preparedness and readiness, and part of our preparedness, of course, was identifying the treatment centers and assessment facilities, doing on-site assessments in the process. From the beginning of the Traveler Active Monitoring that began on October 27th of 2014 all the way through December 29, 2015, we received 2,239 travelers for active monitoring. So active monitoring means that the state health departments would contact the travelers who've arrived from the Ebola-affected countries every single day of the 21-day incubation period while the travelers were in their jurisdiction, and check their temperatures and assess their symptoms if they have any for every single day. And if the travelers were at a higher risk, for example, if they were at some risk or high risk and not just at low risk, then direct observation of their temperatures and symptoms had to be done. And that was direct active monitoring. In general, most of the people came to Northern Virginia. That is 85% of the travelers who were actively monitored were in Northern Virginia, and most were at low risk. 99% of them were at low but not zero risk, which means they really didn't have a direct contact with any Ebola case in West Africa. And those that actually completed monitoring all the way through the 21st day of the monitoring period, so that number is 66%. Some, because of so much traveler movement happening, were transferred to another state or another country, so the monitoring responsibilities were transferred out, and that was about 27% of those who were actively monitored. And once the countries started coming off the list, like when Liberia was declared Ebola-free, Sierra Leone and Guinea were declared Ebola-free, then the travelers were released from active monitoring. This graph gives us a sense of traveler active monitoring over time. The purple color is for travelers who came from Sierra Leone and were monitored in Virginia, and the green color is for travelers from Liberia, and the gray color is for travelers coming from Guinea. And as you can see over here, on June 17, 2015, travelers from Liberia were released from active monitoring because Liberia was declared Ebola-free, and Sierra Leone travelers were released on November 10th because Sierra Leone was declared Ebola-free, and then Guinea travelers were released from active monitoring on December 29th. So this is a graphical display of what we actually did with monitoring and our assessment, I would say. So the CDC would first give us the information of the travelers coming from West Africa in the form of a traveler line list, also known as the DGMQ line list. And in the VDH Central Office, we, the DSI monitoring team, would divvy out that information to the state health departments, and the district monitoring teams would then contact the traveler and note their temperatures and symptoms every day, and gather that information, document that in a form called as a 5B form that would be shared with our central office, and then we would put that information into the database, and then we would continually check our performance to make sure that the active monitoring performance was going well. And the performance measures also would be submitted to CDC through aggregate reporting. If a traveler ever got sick, then they would report their symptoms to the state health departments, and the symptoms eventually, and the traveler would hence be considered for Ebola assessment and care if needed. And you can see that there's a lot of coordination required in that. Our DSI clinical team would be involved, our district clinical teams would be involved, and that was really helpful. I would now give this to my colleague, Mary Beth.
Thank you. I'm Mary Beth White-Comstock, and I'm a consultant here at the Virginia Department of Health, and I'm going to talk to you today about our program that we implemented here in response to this Ebola outbreak. Another important piece to response is hospital preparedness. And at BDH, we look to CDC for much of the guidance that we implement here. Ebola was not like any other disease in that way, except it was a first in many ways. CDC prepared many different guidances in response to the Ebola outbreak, and one of those guidances is this framework here that they developed for hospitals because they knew early on in this outbreak that it was going to be complicated. It was going to be many challenges that hospitals would need, or in states and hospitals would need to contend with. And so they developed this tiered approach or framework for states to use in organizing and managing PUIs within their states. So as you can see from the slide in front of you, there are three tiers or three categories here. The first tier is frontline, and these would be the frontline hospitals. And Virginia did adopt this December of 2014, January 2015. And so the first tier being frontline, hospitals are expected to be able to identify and triage and isolate patients suspected of having Ebola for 12 to 24 hours in this category. And this would include most of the hospitals in Virginia with an emergency department. So every hospital in Virginia would fall into this category. The second tier would be assessment hospitals. Those hospitals would be expected to receive and isolate a PUI and coordinate Ebola testing and other testing. There's a whole list of testing and diagnostic testing that we expect these hospitals to be able to perform. And these hospitals would need to be prepared to keep these patients for up to 5 days. And the third tier being your treatment facilities. And Virginia has 2 treatment facilities, and these hospitals would do all of the above and care for patients throughout the disease process. And I'm going to tell you about our assessment hospitals in detail in just a few minutes, but I do want to say we do have 6 assessment hospitals at the moment. I also want to tell you that we have hospitals that are functioning or have been functioning as assessment facilities, but are not designated assessment hospitals. Those hospitals were identified early on. All states were asked by CDC early in this outbreak in 2014 to identify treatment facilities in their states, as well as facilities that would function as assessment facilities and do some of those duties that needed to occur. And we do have other hospitals in Virginia that have been doing that near our airports. This slide just shows, it's a map of where the treatment facilities and assessment facilities are in Virginia. And as you can see, they are pretty much spread out, and many of them are close to that major airports here in Virginia. One of the the activities that occurred early on in the outbreak were hospital assessments, hospital on-site assessments. CDC coordinated those activities through their office, their agency, and their treatment centers and the assessment centers I mentioned earlier received visits early on in the outbreak to determine their readiness to accept patients. That extended back in January of 2015. CDC shifted their focus a little bit and decentralized those activities, and funding became available for the states. And so Virginia received funding for these activities, and one of those activities was to develop a program to assess the readiness of all the hospitals that were going to be or designated to be assessment and treatment facilities in Virginia and other states. So I'm going to talk to you about this project here. I was hired in May of 2015 to plan and implement this project, and it's been just a great experience. This has been a collaborative effort with the Virginia Hospital and Healthcare Association to assess the readiness of designated hospitals. We used a CDC model and the CDC tool. The methods that we use were standardized methods going into each one of the assessment facilities and treatment hospitals. On this tool, there were 11 preparedness domains. The tool itself was 35 pages. It was a multidisciplinary team that I put together. We had representation from DCLS, our state lab, labor and industry in Virginia, infection prevention. We're lucky enough to have a NIOSH representative that went with us to all of these assessments. And then the district health directors, as well as a regional epidemiologist and their emergency planners were also a part of their team. We conducted on-site assessments, hospital assessments, from January 2015 and finished them up in November 2015. July to November. And in total, we assessed 6 assessment hospitals and 2 treatment. This is a brief snapshot, a little snippet of the assessment tool. As I mentioned, it's a 35-page tool. This is one of the capacities that we looked at. This was the first one, pre-hospital transport plans. This tool was actually given to each of the facilities ahead of time, so they had a sense of what we would be looking for when we actually went into the facilities and assessed them. And this is what we used. We were very familiar with this tool by the time we finished this process. These are the 11 domains that we actually looked at when we went into the facilities. Facility infrastructure, looking at space, looking at communication systems, looking at all the capacities that they would need, the spatial capacities that they would need to take care of a PUI, patient transportation, inter-facility and intra-facility transportation, laboratory safety and testing, what kinds of testing they're able to do, the capacity for testing, the training of staff, PPE. We looked at staffing, the overall staffing plans. Many of these, all of these outbreaks, we spent the majority of the time out in the hospital asking questions, having them go through the actual procedures, and then demonstrating a lot of these practices and procedures that they had implemented or put into place. Training was something we asked them about and looked at. In all of these domains, there were guidances to attach to each one of these that they were familiar with. PPE, we had them don and doff. We had them talk about don and doffing. Waste management, we looked at their systems for waste management. We had them demonstrate how they collect trash in the rooms, what they do with it, who does it, where they put it, how they lock it, where they keep it, who hauls it, that kind of thing. Worker safety was another area. Occupational health was involved. We asked questions about how they monitor their employees. Each employee that works on the unit in the special pathogens or Ebola unit has to be monitored for a certain period of time. We asked lots of questions there. Environmental services, how they clean their rooms, how they clean them every day, how they clean them, terminally clean them, what they use, who does it. Clinical management, we went through some of the procedures, the clinical procedures that that you would think of that some of these patients would need, and some exclusions. We talked about operations coordination and how they would actually put their operations into place in the event that they had a PUI. At the end of each visit, we met with the groups. We had great representation in the hospital, from administrators to the medical staff, to the nursing staff, to housekeeping, and then public relations. We all came together at the end of each of the visit, at the end of the day. It was a day-long visit, and went through our findings. And this is just a snapshot of the summary tool that we used. It's a collapsed version of the other tool that I showed you earlier. It's a 5-page tool that we sort of scored each of the facilities and each of the domains that we looked at. And this was given to them at the end of the visit. So overall, I would say this was a huge success. We learned a lot about the facilities. It was collaborative in nature. We went into that with that approach. I think we learned a lot from our hospital partners. I think we were able to share some of their expertise and help refine some of their practices. But overall, the strengths of these visits, what we took away was their incident command structure in all the facilities was very coordinated, and it was a multidisciplinary approach, and that was very clear in each one of these facilities. There was a tremendous focus on worker safety, environmental EMS transfer. Waste management was another area that was a strength. Selection of personal protective equipment, it was clear they spent a lot of time picking that out and refining that equipment and their practices. Staff training was on the forefront, and telecommunications. There were some areas, as there are always areas for improvement in anything that you're looking at. And some of these are just inherent when you have something like this of this magnitude and needs extra space. In some facilities, there was either limited space or inadequate space. And laboratory services is an area that we are working on. Some facilities aren't able to, or we're not able to run the whole battery of tests that CDC felt like we should be able to run. There were protocols missing in some areas for instance, like management of the deceased, special populations. What do you do with a patient that's needing hemodialysis or some other particular treatment that they had not thought about, and other invasive procedures. The frequency of training, they did an excellent job when they did their initial training. Some facilities had really great training plans in place. Other facilities were working on that when we went in there to do the assessment. And other facilities were also working on enhancing their intra-facility communications within their facility. And then comprehensive staffing plans was another area that we felt like we needed to, the facilities probably needed to tweak a little bit. It requires a tremendous amount of staff to run these special units, and I think you can lay out your staffing plan, but when you start thinking about all the various tasks that need to occur all day long, and the frequency that they need to occur, you run out of staff pretty quickly. And I'm sure that the facilities that have experienced PUIs can attest to that. So the next steps that we have on the agenda in terms of this project, We have been working with each of these facilities to mitigate the gaps that were identified. We are planning a summit in the spring where the treatment hospital, well, the assessment hospitals and the treatment hospitals will be invited. This is a collaborative project where the treatment hospitals are conducting it with us. There is a monthly coalition call, a work group call, where all the treatment hospitals and assessment facilities are represented, and a lot of these topics are discussed month to month. And we do plan to reassess each one of the treatment and assessment facilities every year. Thank you.
Okay. So we're coming at a place where we can take about a 5-minute break so everyone can get up and stretch their legs. And then when we come back, we'll have Denise and Dorothy finish us up.
I think there was some education awareness about removing or mitigating the stigma that you just helping possess that
I think Denise tried to. Where's Diane?
I think our 5 minutes are about up. Sounds good? Okay. So we're going to go ahead and pick back up, and Denise and Dorothy will, thank you, will start presenting for us. Thank you. And you all are ready?
Yes, thank you. We're ready here in Arlington. And right now, we're going to talk about the individual a bit more and talk about our interactions with the people that we were following up, particularly those where there might have been a concern about Ebola. So we're really looking at the case management for an Ebola PUI. And again, PUI stands for Person Under Investigation. And for those of you following along, we are on slide number 28 right now. So when talking about our PUIs, persons under investigation, or potentially a confirmed case, we certainly did a lot to develop guidance. We tried to foresee the different aspects that would come up as we were talking about the PUIs. When we began, we certainly looked at our post-arrival passenger monitoring and had many procedures in place for that. And also looking at the movement of travelers who were under monitoring. If an individual was being monitored in Virginia, if they left the state for a weekend or for a week on vacation during that 21-day period, then that state was notified. So we had protocols whereby we would notify other states, we would notify CDC. If a person was traveling outside of the U.S., we would also notify that country that the individual was traveling and that they were currently under monitoring in Virginia. Sometimes we would continue to do that daily monitoring, or at times that individual was transferred over to their place of vacation or new residence, wherever that might be. But we were trying to develop policies for PUI management, and there were several aspects where we focused. One certainly was on laboratory testing, looking at not just testing for Ebola, but what other tests needed to be done to rule out or rule in other diseases, particularly diseases that were either had symptoms that were similar to Ebola, particularly early symptoms in the course of illness, and also looking at diseases that were more easily contracted from travel to Africa, and the primary one certainly being malaria. So in addition to testing for those diseases, there are the usual clinical tests that need to be done as a physician is evaluating a patient. So we were looking at those tests as well. We also worked on isolation and quarantine, and we have some slides later where we'll focus on that a bit more, but that was certainly an issue that we needed to make sure we were prepared for in case something were to happen. We also had to think about children. Certainly, it could have been a child that was our PUI, so we had to consider the different aspects of dealing with pediatric patients. If it was a pediatric patient and that individual was in isolation, we had to make arrangements for family members or care providers for that child. Those are things that had to be considered. And certainly, if we were dealing with adults, what if they were care providers for children? So we had to think about not just the individual that may have been our PUI, but also other people for whom they may have been responsible. And again, certainly children was one of our primary areas. And then we also had to think about pets. If the PUI had a pet, what was going to happen to that animal if that individual was hospitalized for a period of time? And certainly if that person had Ebola, there were concerns about transmission through pets. So we had to make sure that we had situations available and veterinarians available that were willing to isolate and monitor the pets of those individuals. So there were a lot of aspects in the PUI management that initially you might not have thought about, but as time went on, as we learned from, unfortunately, other cases that occurred here in the United States, we realized that there were so many aspects where we were trying to develop the guidance to go out to our local health departments throughout the state, and also guidance certainly to go to our healthcare providers. We looked at our suspected and confirmed case management, certainly. What would we do if we had a strong suspicion that someone had Ebola? What would we do if the person actually tested positive for Ebola and we had to actively manage a case and deal with the contacts of that individual? Looking at household members, certainly, family and close friends, but if we had a case, we knew that there was going to be a much broader circle of contacts that would need to be investigated. One aspect is the epidemiologic aspect of how the disease is transmitted, but then we also have to deal about the concerns from the community if we were to have an active case of Ebola. So looking at the suspected and the confirmed cases, as well as how we would deal with the contacts. And then if we were to have a case of Ebola in Virginia, there would be a much higher level of concern for our healthcare workers. As we know, with the outbreak in Africa, it was also considered an outbreak among healthcare workers because they were at much greater risk, and we had disease rates that were very high in our healthcare workers in Africa. That's something that we typically don't see with diseases here in this country, and we certainly didn't want to see it if we were to have a case of Ebola. So we wanted to make sure that we had protocols in place for our healthcare workers. And Mary Beth talked about that some when she talked about the assessments with the hospitals, because we were certainly concerned about the PPE for our healthcare workers. And if we had a case of Ebola, then there would be additional monitoring that was required for those healthcare workers. They would then become contacts of a case of Ebola, and they would need to undergo that monitoring period, the 21-day monitoring period that our travelers were undergoing. If there were certainly any kind of a breach in PPE or a needle stick event, then our healthcare workers would become high-risk contacts and would require an added level of monitoring. So those were considerations that we were thinking about in doing our planning for our guidance. We also had to worry about environmental infection control if we were to have a case, and medical waste management. It was surprising to hear how much waste was involved with the care of each Ebola patient. And even for the PUIs that we had here in Virginia, the amount of PPE that is used, even when someone is only in Ebola isolation for care for 1 or 2 days, is astounding. We saw a picture earlier of the PPE that our healthcare workers are wearing. And they can only wear that level of PPE in a room and provide care for a short period of time. It becomes very hot, very heavy. They can't stay in that room for long. So they go through multiple courses, multiple changes, thank you, of PPE during the care for those individuals. And then certainly we have all of the other medical waste products that we would have to manage. And that was really one of the challenges that we had to deal with, was how are we going to deal with the medical waste? And then certainly we have to think about surveillance of our cases, of our contacts, again, if we were to have a case. When we talk about qualified and trained transporters, we're really focusing on our EMS providers. It was important to have EMS providers in each region of the state that were able to transport someone that was suspected of having Ebola. We were concerned about transporting individuals, if necessary, from their home to the hospital, and then from one hospital to another. If they were at a frontline hospital, the individual may need to be transferred to an assessment facility or to a treatment hospital. And as Mary Beth pointed out, we have 2 treatment facilities in the state, and neither one is in Northern Virginia. So if we were to transport a patient, we're talking about several hours that individual would be in an ambulance in order for that person to arrive at one of our treatment facilities. And that is something that we definitely had to consider when we talk about EMS. Some agencies were able to identify a designated vehicle that was only going to be used for EMS transports. But actually most of our EMS transporters within the state didn't have that luxury. I'll give you an example. The Metropolitan Washington Airports Authority, they had what they called their Ebola lance. They had a designated rig that was going to go out of service, but they equipped it so that it would be appropriate to transport individuals that were suspected of having Ebola from the airport to one of the area hospitals that's located near Dulles International Airport. But again, that's not something that many EMS providers could do. Here in Northern Virginia, we did have contracts with 2 EMS providers that would transport from our hospitals in Northern Virginia to our treatment facilities that are located in other parts of the state. So that was beneficial for us. Again, because we had 85% of the individuals who were under monitoring located here in Northern Virginia, we certainly had to make sure that we had those capabilities available to us. And then there was certainly concerns from EMS about providing care to individuals during a 1-hour or 2-hour transport from one hospital down to one of the treatment facilities. They would be wearing full PPE, certainly, and it's very difficult to provide a high level of care in an ambulance for that period of time while they were transporting an individual. So that was a concern that many of our EMS providers expressed, not just for their safety as far as their PPE, but also being able to provide that appropriate level of care when the patient was under their care and being transported from one facility to the next. Many EMS providers did purchase isopods so that they would have an isolation containment unit inside their ambulance. Because if an ambulance was used for transport of an individual that was suspected of having Ebola, that ambulance was really going to go out of service until it was determined whether or not the individual did have Ebola, because that ambulance would certainly need to undergo thorough cleaning, disinfection prior to being used again. So our EMS providers certainly had a lot of concerns on various levels. And we had to balance those concerns with the concerns of our healthcare workers and the concerns of the individual. We did a lot of coordination with our healthcare facilities around the state. And I will say, particularly in Northern Virginia, because we do have Dulles Airport. Next slide, number 29. So we've talked a lot about PUIs. So let's define what we actually mean when we say PUI, or person under investigation. We're really looking for 2 things. The first are symptoms that are compatible with Ebola. The initial symptom we're looking at is an elevated temperature, or someone who has a subjective fever. Some of the other symptoms include headache, fatigue, and we were told that it was really extreme fatigue, then muscle pain. Some individuals developed gastrointestinal symptoms, vomiting, diarrhea, abdominal pain. And then there were those that had unexplained bruising or hemorrhage, which is why we've often referred to Ebola as a viral hemorrhagic illness or a fever. However, only about 30% of the Ebola cases actually developed the bruising or the bleeding, and therefore we didn't use that certainly as one of our primary symptoms when we were considering whether or not a person did have Ebola. The other thing is the epidemiologic risk factor of having been in a country where there was widespread transmission of Ebola within the past 21 days. So we were really looking at both of these conditions. We would receive calls at the health department where there were concerns about Ebola in an individual that hadn't traveled to one of the 3 primary countries. They may have been to another country in Africa. They may have been to other areas where there was some sort of a concern, but they certainly had to have that epidemiologic risk factor of having been in a country where we had widespread transmission. When we talk about the symptoms, and we look at those symptoms, fever, abdominal pain, fatigue, we have to keep in mind that those are symptoms, particularly early symptoms, of many other illnesses, particularly in the early stages. Influenza, malaria, which is something that we see in many people who return from Africa, E. coli, shigellosis. And we were following people for over a year. So during that time, we went through flu seasons, norovirus seasons. And I say that to point out that as we're monitoring people for 21 days, there's a strong likelihood that people will develop some illness. It may not be Ebola. They could have influenza. They could have something in that period that they contracted here in the United States. But in someone who traveled, if they developed fever and the other symptoms that we discussed, we certainly knew that there was going to be a concern about Ebola, both for their healthcare providers and also for those individuals. And that can cause a high level of anxiety for everyone involved. We did have individuals that presented to our hospitals with compatible symptoms, and you could see the individuals, although they were considered to be low but not zero risk, in the back of their minds, they were wondering, I've been to Africa, could this be Ebola? Even though their risk level was low. And our healthcare providers were thinking the same thing. Although the risk level was low, each individual had to be treated as though they may have Ebola, and those precautions needed to be in place. So we had protocols. We worked with our hospitals, but there's never a situation where everything goes completely according to protocol. Other things come up, things arise. No 2 cases were ever the same. Next slide. So as we talk about our procedures for PUI evaluation, we look at the flow chart. Starting in the upper left-hand corner, let's just take a moment and talk about how we learned about some of our PUIs. And even though I'm referring to everyone right now as a PUI, not every individual who traveled and developed symptoms actually reached the status of being categorized as a true person under investigation for Ebola. We were in a very unique situation in Virginia because we do have Dulles International Airport, which was one of the 5 airports in the United States that was doing screening for individuals coming to the U.S. from the 3 affected countries in West Africa. At Dulles, they did passenger screening, and they started passenger screening October 16th in 2014. The week prior to that, we'd had meetings at the airport with CDC quarantine station representatives from the Division of Global Migration and Quarantine, as well as local health districts, the EMS providers, and the hospitals to talk about what we would do if we had a passenger who arrived, and during that screening process, they were identified as having a fever. CDC's recommendation was at that point, that person needed to have medical evaluation and needed to go to a hospital and be treated as though there was a concern about Ebola, so they were treated under full isolation, full PPE. CDC made it very clear to us that the chances of that happening were very slim because there was very good exit screening out of West Africa, so we wouldn't expect for someone arriving in Virginia to have a fever when they were screened. That's what they told us. October 16th was the first day that they started screening. October 16th was also the first day that they identified an arriving passenger with a fever who had to be transported via EMS, not because of a medical need, but because that was the protocol. Transport via EMS to an area hospital where they had to undergo evaluation. So that's the first way that we learned about some of our PUIs, was that they were identified through the airport. So we're rather unique, as I said, in that situation. Another way that we heard about individuals, particularly once we started the monitoring program, was that we asked individuals to contact us. We were speaking with people on a daily basis. We asked that if they were ill, if they developed symptoms, even if it wasn't their regular check-in time, to please give us a call. Let us know that you're ill, and then we can make arrangements for the appropriate medical care. To make sure that if they required EMS transport, it was done in a safe manner. If they were able to self-transport to a hospital, that's even better. And then it allowed us to notify the hospitals in advance so that they would be prepared and not just have someone show up in the emergency department and then happen to mention that they'd been in West Africa in one of the 3 affected countries within the past 21 days so that there was the concern about Ebola. So we certainly asked people to let us know. That didn't always happen. We had several individuals who, whether it was daytime or through the night, developed symptoms and either called EMS on their own without notifying the health department first, or provided their own transportation to the emergency departments and showed up there. So one way that we learned about individuals that were PUIs was from our hospitals when they showed up in the emergency department. And that was certainly the least popular way for us to learn about them. It's better for us to have notice and for us to have been able to notify our hospitals so that they could be prepared. Because it certainly takes a while in the hospitals to clear the rooms that they're using for evaluation for Ebola patients, to make sure that they're donning the PPE and have everything ready so that they can do those patient assessments. So those were actually some of the ways that we learned about the individuals. We worked with our local health departments, the state health department, and we certainly consulted with Centers for Disease Control and Prevention, the Division of Global Migration and Quarantine, as well as the Ebola subject matter experts when we discussed actual testing for Ebola virus disease. If testing was approved, we worked with our state laboratory, the Division of Consolidated Laboratory Services, to ensure that the appropriate specimens were collected, that they were collected at the right times, and that they were shipped appropriately to the state laboratory. Our state lab was one of few laboratories in the country that was capable of testing for Ebola. And they ensured that specimens were able to arrive quickly because they would send out an emergency courier to pick up the specimens. They were also doing testing for malaria as well as some other testing if it was unable to be performed at the hospitals. So while all of this is being done, those individuals are in isolation at the hospital. Our healthcare providers have to use full PPE in caring for those individuals during that entire time period, and we're talking about several hours as they're undergoing the medical evaluation, as specimens are being collected, packaged to be shipped, as an emergency courier is sent. Those samples are then taken down to the state laboratory in Richmond. At all times of the day and night, staff from the laboratory would come back in and do the testing, which took several hours. So there was a long period of time before we would actually have those results, but certainly much faster than if we had to send those specimens down to CDC. If it was determined that testing for Ebola virus disease was not necessary, we would continue to monitor and evaluate that individual while they were in the healthcare facility, and certainly after they were discharged, we would continue with that monitoring. So as you can see, when we looked at our procedures for evaluating the individuals with Ebola, things went in many directions. And again, no two cases, unfortunately, were ever alike. Bless you. Slide number 31. Earlier I said that not everyone that was evaluated actually became, not everyone that was evaluated actually became a PUI, or a person under investigation. But the slide that you see shows the number of cases where we actually considered them to be persons under investigation. Many were tested for Ebola at DCLS. However, many were not. Out of the 31 cases that we considered to be PUIs, we had 11 that were tested for Ebola. And as you're well aware, we did not have any that were positive. In many situations, we never determined the etiology of the individual's symptoms. However, we did have 4 individuals who tested positive for malaria. We also had 2 individuals that tested positive for Shigella, or enteroinvasive E. coli. And with both of those diseases, malaria, unfortunately, something that is rather common. In Africa, we have many people who traveled who did not take prophylaxis for malaria while they were there, and when they came back, they developed symptoms. Individuals with malaria are very ill. They can develop very high fevers as well as other symptoms. So again, when we talk about that level of anxiety of providing care, certainly our healthcare providers understood that. And the individuals with Shigella, not only did they develop fever, but they also went on to develop gastrointestinal symptoms. So again, there were concerns about Ebola. When we consider that we monitored over 2,000 individuals, 2,000 persons who traveled, we probably had 40 to 45,000 days of monitoring. So keep in mind, individuals become ill. They develop various symptoms, and all of those had to be assessed for both infectious and non-infectious conditions. We had to deal with situations where people had other concerns, cardiac issues, surgery, something that we didn't deal with early when we were developing our procedures, but what were we to do when someone traveled and then they needed to have knee replacement surgery? Do they do that during the 21-day incubation period, or do we recommend that they wait? And under those circumstances, we recommended that if it was an elective surgery, that they waited until they were past that 21-day incubation period. So if it was something that could wait, a procedure that could wait, then we definitely recommended that they do that. Slide 32. As I mentioned, we talked a little bit about isolation and quarantine. These are really disease control concepts, but they definitely have legal applications and also implications. Our isolation and quarantine laws had been on the books for many years, but in 2014, we were asked again, as were all states, to take a closer look at those laws. We reviewed our laws again, evaluated them closely, and then also made some changes to help strengthen those laws. So as we talk about isolation, we're looking at an individual who is ill and has the capability to transmit disease to someone else. That's the infectious period that we're concerned about with those individuals. Someone would remain in isolation for their complete period of communicability. We often think about isolation in hospitals. When we look at quarantine, we're talking about individuals who are not ill, they're not experiencing any symptoms, but they've been exposed to a communicable disease. Often it's much harder to talk with people about quarantine because they're not ill and they may question why they need to stay home from work, not go to school, stay in a particular area during that incubation period. As long as people voluntarily comply with our recommendations, then there's no problem. But there are situations where people don't voluntarily comply, and that's why we have to have laws for isolation and quarantine. Next slide, 33. And under those circumstances, we can develop legal orders for isolation and for quarantine. In doing so, we consult with the Office of the Attorney General. We work with our law enforcement agencies throughout the state, the Virginia Department of Emergency Management, or VDEM, and certainly members of the Virginia Department of Health. We developed templates and checklists in order to complete orders of isolation and quarantine, so that if they did need to be developed, they could be developed very quickly. And we worked with our local health districts and also attorneys around the state to make sure that we had all of the legal authorities, that people understood the procedures to request an order of isolation and quarantine, and that they knew how to issue those to the individual, file them, deliver the order. We also had to make sure that our local health districts were prepared for providing the essential needs for isolation and quarantine, which was a responsibility that in working with our partners we had to maintain. And we exercised this throughout the state at many tabletop exercises. 34. And this is just a brief example of a contract we had individuals sign when they were under monitoring, which demonstrates that they understand that if they fail to comply, then there may be legal ramifications. Next slide. 35. There were also other Ebola preparations, certainly, that we had to do. Risk communication was a very large issue when we're talking about a disease that was as scary as Ebola. We coordinated with our health districts, certainly with our hospitals, and many other agencies to make sure that we're providing accurate information to the public and to our partners. Public messaging was done through the Virginia Department of Health website. And we also had to work with risk communication because we're reporting through CDC and also up through our VDH management. Laboratory preparedness is something that we could talk about extensively. Not only did our laboratory purchase the supplies and make sure that our hospitals had shipping kits if testing did become necessary, but they also work to provide guidance and information to all of our hospitals, as well as to do the testing for us. Slide number 36. There were also other trainings that were done. We did fit test trainings with our hospitals and with our health districts. A video was developed for law enforcement so that they would understand more about Ebola and also about what their role may be if we were to have a case. We had our state unified command. Jody showed earlier the chart of our unified command system, and we had tabletops as well as workshops for our hospitals and our local health departments. So there was a lot of training that was done around Ebola. People often asked why so much was done when we didn't have a case. It was really because we needed to be prepared in Virginia, and we wanted to make sure that we were prepared. Next slide, number 37. Our MRC volunteers are really considered an extension of the health department. We value your support, and there are many ways where we felt that your support could be used. Certainly with communication with the public, and we're talking about those where there is a risk of exposure. In all of our surveillance and investigation methods, anywhere where health department staff are working, we thought about ways where MRCs could provide that support. The monitoring for individuals, certainly who were under our daily monitoring program, but also looking at surveillance if we were to have a case and we had to follow up on contacts, do symptom checks. There's so much that's involved with that. And we certainly don't have staff with the health department to be able to do all of that. So we really do rely on the support that we get from our MRC volunteers. There's also the data management aspect where we felt that MRC volunteers could certainly provide that support, as well as anything else that may come up. We definitely see you as a resource. Next slide, number 38. Mary Beth talked some about the infection control that we had to look at with all of our facilities, our frontline facilities, as well as certainly the assessment facilities and our treatment facilities, looking at the risk communications, making sure that they had the appropriate plans and procedures in place and that they had the resources involved. We also had to coordinate among many agencies. When we talk about our statewide unified command, Ebola was not an issue that could have been handled by the health department alone. We were certainly the lead agency, but we had to work with our other support agencies for all of the different aspects that were involved, whether we're looking at case management, our hospital preparedness, the data management, and all of our legal aspects. The things that we learned from Ebola, we are certainly able to apply to other diseases and to other disease outbreaks. We have increased awareness and education, even with the roles that the health department provides within our community. Our disease prevention, the coordination and the collaboration that was involved, we had new ways and had to identify new ways to solve problems and to deal with the large amounts of data that were involved when you're monitoring a couple of thousand people for 21 days. There are also research studies that have been done that will hopefully provide background, basis, and support to preventing outbreaks in the future. And we certainly had to deal with a lot of public fear and stigma associated with Ebola. Hopefully, each time we do that, we learn how to handle it better, and that will transmit over into future disease outbreaks. So now I will turn it over to my MRC counterpart to talk some more about the MRC response.
Hi there, y'all. Dorothy Bierenesser, slide 41. One slide. So, really like to emphasize that there are a number of things that MRC volunteers can do, and frankly, the most important is the non-nursing trained ones. Data entry, data entry, data entry. I've been volunteering since 2009, and that's still the biggest job that I see. monitoring creates lots and lots and lots and lots and lots of data. And you don't have to have RN after your name to do data entry or data correlation. So please, volunteer. Let me roll from measles contact investigations, which we've assisted on, to what actually was my, I think the phrase is lived experience of Ebola. And let me reemphasize something that was said earlier. The first thing you can do is to help address public fear. I work in a government building. One day, a lady puked outside in our parking lot and said she had been to West Africa. I'm not kidding. I was talking people off the ledges and from running out the doors going, no, really, it's okay. You're not in danger right now. And I'm not saying that because my coworkers are silly people. They're not. They're highly educated people. But they're subject to fear. And there were a lot of very afraid people that day. By the way, she hadn't been to Africa, so that was that other thing that took her out of the PUI realm.
Yes, I remember that day very well.
Yes. So, but the first thing you can do, educate yourself and work with the people you work with. Help manage the fear. Help manage the stigma. More importantly, 2,200 people, give or take. 21 days of monitoring each. Did we mention this was over Christmas? Well, we should mention that. The Fairfax County Health Department wasn't staffed to monitor, gosh, I think you guys were up to like 30, 40 cases a day in some points of monitoring?
Yes.
Somewhere in there. I never counted all the charts, but there were large quantities of charts. So what did we do? We came in, we got just-in-time training, which involved the flow charts and the algorithms they used to determine whether a person was low risk, some risk, or high risk. As MRC, we only worked with the low risk cases. Health department focused on any of the sums or highs. We didn't see those. The monitoring kind of worked like this from our perspective. By 10 o'clock in the morning, the poor health department nurse had an email full of, yes, I checked my temperature last night, it was this. Yes, I checked my temperature this morning, it was this. No, I don't have any symptoms. No, I don't intend to travel. That was a classic email or a classic text. If by 10 o'clock she had checked off her list and she still had a pile of people who hadn't checked in, that's what we did. We each got our little pile and we started making phone calls. And our regime was, you tried calling once. If you got no answer, you marked that you called once. You waited about an hour, worked down the rest of your list. You called again in an hour. You got no answer the second time. As I remember it, you marked it down and you waited one more hour. And if you didn't make contact the third time, you then advised the public health nurse that you had failed to make contact. Because that chain of events could have gone all the way to them figuring out whether they had to issue a notice of quarantine. And you had to be polite, because it's Saturday morning. It's Sunday morning. These people are not happy with you. Some of them have been very, very cooperative, and some of them are really, really irritated, and you have to deal with both of those on the telephone and be respectful while getting the information. Luckily for us, language barriers weren't too bad, but it got iffy a couple of times. Again, we bring it back to the health department nurse if we felt that we were not communicating properly with this individual. That's kind of where the nursing training starts rolling in again, because as a nurse, you kind of know when you're not getting through. And it's your job to let them know that you don't think you made communication well with this person. Checked off all the lists, checked other lists, and the day would vary depending on how many cases they had. Bear in mind, the health department is also every day getting a new list of people who came in through Dulles. And sending out individual nurses to go make the individual contact assessment. We did not assist with that as far as I know. It was kind of a double backup plan if it got really bad. So I didn't specifically evaluate a client. I did staff the call center. Yay. A lot of us did. Thank you to everybody who staffed a call center. Thank you, thank you, thank you. And that was really kind of my lived experience. Thank God we didn't have Ebola, so we didn't have to do all the contact calls and make that lovely little cold call. Hi there. I hesitate to inform you that you may have been exposed. How you doing today? So I speak flippantly. I took the experience seriously. But I do want to re-communicate. There's a lot that we can do to assist the health department. Don't be afraid to ask.
Yes.
And with that, I'll turn it back over to the hostess.
Okay. So we want to go ahead and thank Jyoti, Mary Beth, Denise, and Dorotha, for that informative session. We understand time is getting away from us. I just want to take a couple of minutes before we do our Q&A. Sarah Keeley is in Fairfax. She's actually an emergency management specialist at Fairfax Health Department. She was the section chief for the Ebola situation. And if she's on the line, can she just take a couple of minutes, Sarah, to just tell us your experience with this?
Hi, yes. I work for the Fairfax County Health Department, and I served as the logistics section chief throughout the Ebola monitoring and response. And like Dorotha and Denise mentioned, we used the volunteers in a variety of little different positions. We did provide them with an introduction to training for Ebola, about the algorithms that we did. We tried to incorporate them into our monitoring group, especially for weekend and evening work, where we didn't have as much staff for that coverage. Also, we did do a call center, so we had them come in and be call screeners and call takers in our call center to help address questions from the public as well. We did identify a number of volunteers to do the assistance for on-call as home visitors, but we didn't end up needing that resource, but they were there in case we did. Those would partner with one of our home visit nurses who would go there and assist them with completion of the traveler agreement and any other information they need to gather from that person. So that's kind of the majority of what they did, but with the data entry and everything, it was very helpful to us, especially over weekends and holidays when we didn't have as much staffing as we could have had. So it was a good learning experience, and we will carry it forward for the next incident, whatever that may be. So.
Okay. Thank you, Sarah, for sharing that. So we just want to take a couple minutes to see if there are any questions from Jyoti, Mary Beth, Denise, or Dorotha. If anyone out there has any questions. No questions?
One question. So what are the treatment hospitals, and why isn't one near Dulles Airport?
The two treatment hospitals are VCU and UVA.
Okay. Any other questions for our speakers?
Dulles is the international airport for this huge region. It sort of boggles the mind that someone wouldn't do something big here to sift through. Why go so far away?
Yeah, I understand what you're saying. The initial discussions, I was not here during the initial discussions, and Denise might be able to speak to this better than I can. But my understanding, as with all the treatment hospitals across the country, is the discussions were held with the health department and hospital partners to identify these, and hospitals had to be willing to accept these patients and have the capability of doing so. I don't know if you have anything to add to that, Denise.
Just shame on Fairfax Hospital. Sorry.
That was not from Denise, by the way.
No, that was from me. My name is Lorraine. I'm a participant, but shame on Fairfax. It's a huge regional, big name hospital, and if they refused, shame on them.
I will just add that what Mary Beth said was correct. Hospitals had to volunteer in order to be treatment facilities. But I will say that we do have several hospitals in Northern Virginia that are more than capable of caring for an individual with Ebola.
Yeah.
And we had several PUIs, many PUIs and individuals who were under monitoring that did seek cares at our hospitals in Northern Virginia. And many of them, three, had actually undergone a CDC assessment. They had passed it with flying colors. So we have capable hospitals, and they were seeing individuals who were under monitoring. So they did fulfill that obligation.
Thank you.
They just didn't go through the process to become an official treatment facility.
Okay.
Yes.
One quick question. NIH and several Ebola treatment facilities in the DC area are significantly closer to us. Is there a way that an Ebola or a PUI from Northern Virginia could go to one of those facilities, or does they have to stay in Virginia?
Did you guys get that question?
The question was about treatment facilities, including NIH and some in Washington, D.C., that were closer than UVA or VCU. We did actually have some Virginia residents that were seen at hospitals in the District of Columbia. NIH was primarily reserved for U.S. citizens that were being brought back into the U.S. from West Africa. So they had asked that states identify treatment facilities within their borders to see individuals who were already here and under monitoring. So we had 2 facilities that stepped up to the plate and were more than willing and capable to do that. But we certainly did look at other facilities, and we have a regional facility with Johns Hopkins that was also willing to take individuals.
Okay.
We have a question, Fairfax.
Okay, Fairfax, go ahead.
Very recently, a British subject who had recovered about 2 years ago from her Ebola infection returned to the UK with a second-time sequelae associated event. Is this anything that we need to be concerned about from a public health perspective? And should that mean screening should be ongoing at, at our international airports?
Who wants to take that? Who wants to take that?
I'll go ahead and take that one. This was certainly the largest Ebola outbreak that the world had seen. So we're learning a lot more about the disease, about the sequelae that are involved with it, as well as many other aspects. So whether or not we really need to be concerned because we have one individual that's having possible recurrence or sequela, I don't think that's really the main issue. But do we need to remain vigilant? Absolutely. There have been subsequent cases in some of the West African countries. There certainly could be cases in the future. I don't think that we need to continue the level of screening that we've been doing throughout our patient monitoring program or our traveler monitoring program. But I do certainly think that the world needs to remain vigilant. We've had one outbreak. We can have others. They're definitely remaining vigilant in West Africa. A lot of their surveillance activities are still remaining at a very high level. So although I don't think we need to do that here, those activities are occurring and will be occurring for quite some time in West Africa.
Okay.
Hi, this is Chesterfield. I have a question.
Okay, go ahead, Chesterfield.
Okay, is there preparedness in place for a potential Zika outbreak? And how might that be different as far as the preparation than it was with Ebola? How may that differ?
We are definitely preparing for Zika. We have been preparing for quite some time for Zika virus. We are currently testing individuals that meet certain criteria for Zika virus. It is a very different disease. It is transmitted differently. It is transmitted primarily via mosquitoes. While that's not a concern right now because we are in March, we are looking to the spring and the summer and surveillance activities that may need to be done to see if the virus does arrive in our area and to determine whether or not it's transmitted here. We learned a lot from Ebola, and a lot of those activities are transferring over to Zika virus. We had many staff that were working with the monitoring of Ebola virus, and those individuals are now also working with the monitoring for Zika virus and our Zika virus testing program. So yes, the things that we learned from Ebola, we are very quickly able to apply to another new and emerging infectious disease.
One more question in Fairfax.
Okay,
Thank you.
Well, you said that you were telling other places when somebody transferred out. Were they reciprocating and telling you when we got people in?
Absolutely. It was a very dynamic process. People constantly were coming into the program, leaving the program. We were monitoring people in other states. Sometimes other states were monitoring people who were currently in Virginia because they were only going to be here for a day or two. So that occurred on a regular basis. And it's hard to imagine the amount of data involved with that when you're looking at individuals. If they were coming to King's Dominion for a day, then we were informed about it. And that local health district was informed that someone who was under monitoring was going to be in their health district. So that was a very interesting and somewhat complicated process that worked surprisingly well. It amazed me that within the United States, we had such an awareness of individuals who had recently traveled to West Africa and where they were within the country.
And this is a logistics question. You said you had ambulances when they took patients to the treatment or the assessment places. They had to do the isolation pod maybe if they had one. They had to be in full protective gear. What about on the return trip? Did they have to drive back in the protective gear as well? Because you said the ambulance might have been infected. They wouldn't have known that at that point. What did you do with the ambulance on the return trip?
So the ambulances, one of the issues with EMS was that ambulances are often accustomed to going to certain hospitals. And now we're asking them to go outside of their region, to go to various facilities where they may not have that same level of familiarity. But when they arrived at the hospital, they did doff their PPE, their protective equipment. There was often some cleaning that was done to the rig, and those rigs were set aside. I don't believe that they were in the back of the ambulance at that point, but we certainly notified EMS when it was clear for that ambulance to be used again. Because as we are monitoring people, if someone was hospitalized for a day or two, they had a fever, they had some mild symptoms, if their illness did not progress, then they didn't have Ebola. So we were able to monitor people for a period of time. Sometimes it was 24 hours, sometimes it was 48, and determine that it certainly wasn't Ebola, even without sometimes testing the individual.
All right. Are there any final questions before we close? Okay. If you do, feel free to send me those questions, and I will get them to the speakers. We want to thank Jyoti Gupta, Mary Beth White Comstock, Denise Sockwell, and Dorotha Bisniers. I say it different every time, Dorotha. I'm sorry. But we want to thank our speakers on tonight for providing this information to us. We want to thank all of those volunteers who are on the Polycom on the line. We want to thank you all for spending the evening with us. Yeah, give yourself a hand. Yes. If you have any questions, contact your local, MRC coordinator.